Hello everyone. So welcome to you all to our Pediatrics University question answer discussion. So in this video, we are going to discuss about some hematological disorders of the pediatrics. Among that, some of the usually asked question patterns are about the iron deficiency anemia, about the lab investigations, clinical features, and management of iron deficiency anemia, then about the thalassemia, then about the sickle cell anemia, and also about the iron chelation therapy. So these are the usually asked questions in the hematological disorders of the disorders in the children. So first we begin with the iron deficiency anemia. So the usual questions are regarding the iron deficiency anemia are the describe the etiology, clinical features, and management of the iron deficiency anemia in the children. Then about the short note on the oral iron therapy. Then about the microcytic hypochromic anemia in the children. So these are the short notes which are usually asked regarding the iron deficiency anemia. So, as an introduction, if an any essay question or short note or short essay is asked in the case of in regarding the iron deficiency, we have to give an introduction. That is, iron deficiency anemia is the most common micronutrient deficiency. 50% of anemia prevalence is attributed to iron deficiency anemia. That is about half of the anemia prevalence is attributed due to iron deficiency anemia. Then high prevalence of this iron deficiency anemia in the pediatrics age group is due to limited iron stores at a birth and delayed introduction of complementary feeding and timing of umbilical cord clamping. And if there is delayed cord clamping, that will restore the entire blood from the cord into the baby, and that will prevent the anemia from developing. But if there is any early cord clamping, will be that results in the anemia. So the timing of the umbilical cord clamping is also important, and the complementary food insufficient and poor in iron. So these are the causes for the high prevalence of the anemia in the children. Then about the global prevalence, 30% of world's population is iron deficient and 43% of young children are also deficient of the iron. Then about the Indian incidence of the iron deficiency anemia is that in the preschool children, that is about 1 to 3 years of age, that is 70% of is due to iron deficiency anemia, and 3 to 6 years of age, 45%, in the adolescent, 50% of the anemia is due to iron deficiency anemia. These are the daily requirement of the iron. That is in the 1 to 10 years, we have to require, we have the requirement of the 10 milligram per day. In the full term infants, 1 milligram per kilogram per day from 4 months of age. Then in the low birth weight babies, there will be increased requirement, that is 2 milligram per kilogram per day from 2 months of age. Then if the babies is less than 1 kilogram weight, we have to supplement increased amount, that is 4 milligram per kilogram per day from 2 months of age. If the baby is between 1 to 1.5 kilogram, we have to supplement 3 milligram per kilogram per day from 2 months of age. So these are the daily requirements of the iron in the case of the children. Then about the source of the iron, the heme iron, that is red meat, fish, and the poultry, it is better absorbed than green leafy vegetables. Like these are the very good sources, but less bioavailability as compared to red meat. So red meat is the best. The bioavailability is there. Then non-heme iron is get through these nuts, dates, pulses, jaggery, and dal. So jaggery and dates and red meat are the important sources for the iron. And iron in the breast milk, low levels of the iron in the breast milk lasts 0.5 milligram per liter, but better bioavailability will be there. So these are the sources for the iron. Then absorption of the iron is promoted by the ascorbic acid, heme iron, germination, and fermentation, and absorption is inhibited by the phytates, that is in the case of that is included in the cereals, then tea and coffee, calcium, and soy protein. So then that is all regarding the introduction. That is, we discuss about the prevalence, then daily requirement in the children, and sources and absorption, promoters and inhibitors. Then about the important sub-question, that is regarding the causes of the iron deficiency anemia. The causes of iron deficiency anemia is divided into different heading. That is, it is because of decreased iron stores and decreased intake of the iron and increased losses during the any bleeding and the hookworm infestation and increased demands during certain conditions and also poor absorption. So these are the headings that is divided basis on the causes of the iron deficiency anemia. There are five headings. The first heading is decreased iron stores. That is the case of the preterm and small for gestational age baby and twins. There will be decreased iron, so that will result in the iron deficiency anemia. And the next heading is the decreased intake. Because of this decreased intake of the iron, that results in the iron deficiency anemia. That is due to, in the case of malnutrition, non-breastfed infants, that is cow's milk feed, delayed introduction of complementary feeding, complementary food deficient in the iron, and chronic infection, and food pads in the and food facts in the adolescents. So these are the causes for the decreased intake of the iron, which results in the iron deficiency anemia. The next heading is the increased losses of the iron, that is during the hookworm infestation, GI bleeding, malaria, bleeding diathesis, repeated blood sampling, menorrhagia, that is females, there will be loss of 40 ml blood every month. So the menorrhagia also contributes to increased losses. Then fetal-maternal bleed. So these are the causes for the increased losses that leads to iron deficiency anemia. The next heading for the cause is increased demand during certain conditions, like in the case of prematurity, low birth weight baby, and adolescent girls in pregnancy and lactation. These are the condition where there will be increased demand for the iron. So that will result in the relative deficiency of the iron. That results in the iron deficiency anemia. Then another heading is the poor absorption. That is, we adequately consume the iron, but there will be poor absorption from the gut. That is due to malnutrition, chronic diarrhea, celiac disease, and post-GI surgery of the Meckel's diverticulum, etc. So these are the causes for the iron deficiency, that is divided into five headings. That is decreased iron stores, decreased intake, increased loss, increased demand, and poor absorption. Then about the stages of the iron deficiency anemia, there are three stages. That is, first stage is iron storage depletion, and the second stage is iron deficiency without anemia, and third is iron deficiency anemia decreases the hemoglobin. Then about the clinical features, it is also asked as a short note, that is clinical features of iron deficiency anemia. So the usually that is the iron deficiency anemia, that is a systemic disorder. The peak incidence is at the 6 months to 3 years of age and 11 to 17 years of age, where there will be a requirement is maximum. And therefore, there will be peak incidence of the anemia will be there. Then appearance of symptoms which depends upon the rate of fall of hemoglobin. If there is a gradual fall in the hemoglobin, there will be symptoms will be developed insidiously, that is gradually, and a symptom unnoticed till hemoglobin 4 to 5 gram. And if there is a rapid drop of hemoglobin, there will be signs of congestive cardiac failure or shock will be there. And initially, that is initial period, we have the symptoms like irritability, pallor, anorexia, that is loss of appetite will be there. So these are the initial symptoms of the signs of the iron deficiency anemia. Then also we have the behavioral changes like shortened attention span, irritability, decreased cognition, and breath holding spells. That is spasm in the less than 3 years of old child. Then about the late manifestation, the child developed palpitation, shortness of breath, easy fatigability, reduced exercise tolerance, growth retardation, pica, that is in 70 to 80% of kids, that is the ingestion of non-nutritive substance, then that is response to iron therapy, then craving for the inedible things, that is clay, etc. That is a pica. So these are the late manifestation, and the signs are the plateonychia, koilonychia, that is flattening of the nail, koilonychia is spawning of the nail, glossitis which may be present, but their absence does not rule out the iron deficiency anemia. And the mild hepatosplenomegaly is also not uncommon, but huge organomegaly warrants investigation to rule out the hemolytic anemia. So usually in the hemolytic anemia cases, there will be huge organomegaly. So the if a question is asked regarding causes of pallor without anemia, this is shock, vasovagal shock, and syncope and edema. These are the causes for the pallor without anemia: shock, vasovagal, syncope, and edema. Then about the lab investigation, it is also asked as a short note or the short essay, that is regarding the lab investigation for the diagnosis of the iron deficiency anemia. So we have both tests, that is screening test and confirmatory test. In the screening test, there is hemoglobin is reduced, RBC count is reduced, and the mean corpuscular volume is reduced, and the mean corpuscular hemoglobin is reduced, mean corpuscular hemoglobin concentration is reduced, and hematocrit is also reduced in the case of the iron deficiency anemia, and the red cell width is increased. So these are all regarding the screening test. We have to go for the hemoglobin, RBC count, and the MCV, MCH, MCHC, and hematocrit, and also red cell width. Only red cell width is increased. Then regarding the confirmatory test, these are serum iron less than serum, that is serum iron is less than 50 milligram per deciliter in the case of iron deficiency anemia, and the serum ferritin is also decreased, that is less than 10 to 12 nanogram per milliliter. Then transfer in saturation is also less, it is decreased, that is less than 14 percentage, and serum iron binding capacity is increased, and the that is total iron binding capacity is increased greater than 470 microgram per deciliter. Then FEP by hemoglobin ratio is greater than 5.5, and the serum total ferritin transfer in saturation divided by ferritin greater than 4. So only from this confirmation we have to study about the serum ion value, serum ferritin value, transfer in saturation, and the total ion binding capacity. The total ion binding capacity is increased greater than 470 microgram per deciliter, but in the case of this serum ion and serum ferritin transfer in saturation, it is um, also decreased. That also the stainable iron from the bone marrow is also reduced. That is all regarding the confirmatory finding. So we have screening test and confirmatory test is there. Then also we have to look for the blood smear, that is microcytic hypochromic picture is the thrombocytosis will be the. So these are regarding the diagnosis of the or the lab investigation for the diagnosis of the iron deficiency anemia. Then about the differential diagnosis, anemia of chronic disease have a similar picture. Then thalassemia, lead poison, that is microcytic hypochromic anemia is due to thalassemia major, lead poisoning, anemia of chronic disease. But in the lead poisoning, there will be piece of slipping on the smear will be there. And in the thalassemia, to differentiate that, we have red cell width is normal or which may be very high in the thalassemia major. But in the case of the iron deficiency anemia, red cell width is high, increased. So this is the algorithm for the differential diagnosis of microcytic hypochromic anemia. That is microcytic hypochromic anemia is the MCV value is less than 80. And if this picture is getting in the peripheral blood smear, we have to look for the serum iron. And if the serum iron is decreased, we have to look for the ferritin value. And if the ferritin is decreased, that is indicative of the iron deficiency anemia. And if the ferritin is normal or increased, anemia of the chronic disease is suspected. Then in the case of the serum iron is normal or increased, we have to go for the hemoglobin electrophoresis. So to rule out, so hemoglobin electrophoresis is abnormal, that is indicative of either thalassemia or hemoglobinopathies. But if the hemoglobin electrophoresis is normal, that is an indicative of the sideroblastic, that is bone marrow, there will be increased iron stores will be there. That is all regarding the approach towards the microcytic hypochromic anemia. So these are the table which showing the DDs in iron deficiency anemia from the thalassemia minor and anemia chronic infection. So these should be also kept in mind. That is anemia in the iron deficiency anemia, there will be pica is present and the RBC count is high in the case of thalassemia minor, but in the other two conditions it is low. And the MCV is low in the case of both iron deficiency anemia and thalassemia minor, but in the anemia of chronic disease, the MCV is which may be normal or low. And the red cell width which is high in the case of both iron deficiency anemia and anemia of chronic disease. But in the case of thalassemia minor, red cell width is normal. And the total iron binding capacity is high in the case of iron deficiency anemia and the anemia of chronic disease, but it is normal in the case of thalassemia minor. And the ferritin is low in the case of iron deficiency anemia only, but in the thalassemia minor it is normal, but in the case of anemia of chronic disease, it is high. Then about the HbA2, which is normal in the iron deficiency anemia, high in the case of thalassemia minor, and normal in the case of anemia of chronic disease. Then about the Menzel index, that is to differentiate between iron deficiency anemia and thalassemia minor, that is greater than 30 in the case of iron deficiency anemia and less than 30 in the case of the thalassemia minor in the case of the Menzel index. Menzel index is equal to the MCB divided by the RBC count. So it is to differentiate between the iron deficiency anemia and thalassemia minor. This is the important index. Then iron response, there will be good iron response to the treatment in the case of iron deficiency and poor response towards the iron in the case of thalassemia minor and anemia of chronic disease. So these are all regarding the differential diagnosis between the iron deficiency anemia, thalassemia minor and anemia of chronic disease. Then about the management, the goals of treatment is the iron therapy, including replenishing stores. There is oral or parenteral supplementation. Then treatment of the underlying cause and prevent recurrence by the diet counseling, iron supplements, and fortification of the food. Then about the oral iron therapy, it is also asked as a short note. The advantage of the oral iron therapy is it is cheap, effective, safe, convenient, and well tolerated or preferred. And the timing is best absorbed on the empty stomach or between the meals in divided doses. Bedtime also there will be better complaints and less gastric disturbances will be there. And the duration is at least 2 to 3 months after hemoglobin normalizes, usually by the 2 months. And the dose is preventive. For the preventive supplementation, infants we have to give the oral iron therapy as the dose of 4 to 6 months age. Then in low birth weight baby greater than 1.5 kilogram from the 2 months. In the low birth baby less than 1.5 kilogram from the 2 weeks till toddlerhood, 2 milligram per kilogram per daily. Therapeutic dose is 3 to 6 milligram per kilogram per day elemental iron. Then salts available in the oral iron as ferrous salt, ferrous fumarate, and ferrous sulfate. Usually, the best and cheapest is the ferrous salt. Then, about the forms, uncoated tablets are used, and entry coated tablets are also there, and syrups or drops are also there. And absorption, along with the iron oral iron therapy, we have to avoid the tea and better absorbed along with the vitamin C. Then side effects of this oral iron therapy are nausea, vomiting, constipation, diarrhea, abdominal discomfort, black and staining in the teeth and tongue. Rarely iron poisoning by the accidental overdose will be there. Then instruction to mother while giving the oral iron are staining of the stool will be that is if we give the oral iron therapy, the stool will be black in color, so it should be uh, told to the mother it is normal. Then tongue and teeth blackening will be there also. These all should be instructed to the mother. Then alternative regime is the once or twice a week oral iron treatment is found to be equally effective with less side effects. Then response treatment usually occurs in 12 to 24 hours, like replacement of the enzymes, subjective improvement, decreased irritability, and increased appetite. In the time period of 24 to 40 hours, there will be erythroid hypoplasia. 48 to 70 hours, there will be reticulocytosis. And in the 4 to 20 days, there will be increase in the hemoglobin level. That is, hemoglobin rises slowly at 0.4 gram per deciliter per day, normalizes in the 6 to 8 weeks, and 1 to 3 months, there will be replenishment of the stores will be so there. So that is the response towards the treatment with the oral iron therapy. Then failure of the oral iron is the wrong diagnosis, wrong dose, wrong length of treatment, poor complaints, decreased absorption due to the GI disorder, and too much tea consumption and ongoing GI losses. In these conditions, there will be failure of the oral iron therapy. So that is all regarding the oral iron therapy. That is a treatment option for the iron deficiency anemia. The next treatment option is the parenteral therapy. It is almost never required. If the route is IV or IM, and indication is intolerance to, if there is an intolerance to oral iron, or if there is malabsorption or gastrointestinal bleed aggravated by the oral iron, we have to supplement the parenteral therapy of the iron. Preparations are the iron dextran, iron sucrose, iron ferric gluconate, and iron polymaltose complex. And dose is calculated by the formula weight in kilogram into hemoglobin deficit gram by deciliter into 4. Side effects of this parenteral iron is pain, anaphylaxis, hypotension, and cardiac arrest. Then another treatment method is we have to give the blood transfusion. That is only in the emergency situation. Example, if there is a severe anemia at the CCF, we have to give the blood transfusion. 50 ml per kilogram of the freshly prepared leukocyte depleted packed RBC should be supplemented, then followed by the oral iron therapy. That is the treatment option for the iron deficiency anemia. That is oral iron therapy, parenteral iron therapy, and the blood transfusion. Then about the prevention, we have to give the exclusive breastfeeding with the burping, supplementation to pregnant women and adolescent girls, iron folic acid, 100 milligram elemental iron weekly dose, and iron supplementation to low birth weight babies and preterm babies from 2 months to till 1 year of age. Fortification of food with iron, that is 1 milligram per gram of salt, micro encapsulated iron sprinkles in a novel approach, and this can be sprinkled on any complementary food. Cooking in the cast iron utensils encouraged, and control of infections, that is both bacterial and parasitic, regular deworming. So National Anemia Prophylaxis Program and Iron Plus initiative is also that encourage the iron, or that prevent the occurrence of the iron deficiency anemia. So that is all regarding the iron deficiency anemia.